Assalamu alaikum, everyone. I have changed the settings on our WhatsApp system so that you can let me know in case if people are having difficulty in hearing. So let's start our session today. So it's an absolute pleasure to welcome you all, and it's absolute pleasure to have you all for today's session. So today's session, we are going to concentrate mainly on spondyloarthritis, juvenile spondyloarthritis. So it will be a dedicated spondyloarthritis session today, inshallah. Fortunately, he is going to be missing out from some earlier session. He's unfortunately off sick. He was having chest infections and so on, and was on injectables, and also he's having some other commitments as well at the same time. So he will be joining us, inshallah, in some time in the later session. So juvenile spondyloarthritis, so as I was saying, today is all about juvenile spondyloarthritis. The whole session we'll be discussing about 2 hours plus minus on juvenile spondyloarthritis. So this is today's agenda. We'll be discussing about juvenile spondyloarthritis. Initially, there will be a little bit of introduction, and then we'll be focusing on juvenile spondyloarthritis. In the second session, we'll be talking about the patients, and we'll be asking the patients and their family about their own patient journey. And the last session will be imaging in spondyloarthritis, and we'll end with our question and answer session. So I think it's vital and it's very important that I'll introduce you with the concept of spondyloarthritis. I'm mindful that majority of the audience and the participants are not having a lot of rheumatologic background. For rheumatologists, of course, they're very much aware of this term, that where it comes from, but for non-rheumatologists, of course, it is a little bit too much to expect regarding having a good understanding. So I'm going to brief you a little bit about spondyloarthritis, because in adult patients, when we talk about spondyloarthritis, is very much well defined. We know clearly as regards the pathogenic backgrounds and so on. And I strongly believe that for years and years to come, the pediatric spondyloarthritis will follow the principles, the management guidelines based on the adult spondyloarthritis, because there are much more similarities rather than having any major differences there. So let's look at the scope of the back pain. So we know the spondyloarthritis, naturally it starts with the back pain. So this is the principal symptom of spondyloarthritis is the back pain. So if you look at the scope is very wide. For example, 80% of the patients in the UK population are going to have back pain at some point in time. So again, we cannot, of course, focus on all those 80% of the general population when we are talking about spondyloarthritis. And you'll be glad to hear that only 5 to 10% of the back pains originate from the inflammatory back pains, means coming from spondyloarthritis or the arthritis of the back. And that is the one where the rheumatologists are more concerned about. So this is what we call inflammatory back pain. In simple word, it comes from the inflammation of the back, and it predominantly affects the lower back, buttocks, and the structures of the spine. And sometimes, of course, there will be peripheral joint involvement. It is, as I said, is the main symptom of spondyloarthritis. And of course, if it gets untreated, there is undoubtedly going to be some ankylosis of different joints of the back. If we look at the prevalence of inflammatory back pain, you'll be amazed to hear that 3.4% of the general population presenting to the UK, general population going to have inflammatory back pain. In the Dutch, for example, this study which I've quoted there, what they did was, you can imagine that how much this inflammatory back pain or spondyloarthritis is prevalent in the general population. In the Dutch people, what they did was, they simply looked around the younger people walking around with the back pain lasting for more than 3 months. Simply lasting for more than 3 months, all the young people walking around with the back pain, they did the full clinical assessment of these patients. And what they found out was that every 4th of the young people walking around have undiagnosed spondyloarthritis. So it's so common, in other words, but also at the same time, it's undiagnosed and of course is underappreciated. So what are the common features of inflammatory back pain? It's very simple. It takes less than 2 minutes or probably 1 minute to elicit inflammatory back pain. What I mean from that is that the inflammation is there more in the morning time. There's the early morning stiffness. It's worse at night time. When the patient sits down for a longer period of time, they feel that the back gets stiff. The back gets, for example, the tight and all this. When they walk around, they feel better. So they feel, it's what we call gel phenomena in simple words. What I mean from that is when they sit down for a period of time, when they're inactive, of course, the whole back and the spine gets like a gel phenomenon. When they walk around, they feel a bit more easy. So that's why the pain is worse at nighttime, pain is worse in the morning time, when the walk around is easier. And of course, it's insidious onset, means of course it is not associated with any trauma or anything. And there is a dramatic response to NSAIDs. So you can imagine how easy it is to elicit inflammatory back pain. When you compare this inflammatory back pain side by side with the mechanical or the degenerative or the muscular pain, in other words, you can see there are very clear differences there. For example, the morning, of course, some mechanical or the wear and tear pains, they can be stiff a little bit in the morning, but that pain in the morning is quite sort of, it doesn't last that long. It's only for a few minutes. It doesn't last for hours, for example. So the pain is worse at nighttime, but the mechanical pain, of course, is better with rest. So when they're resting, of course, they're better. When they walk around, of course, the mechanical pain or the degenerative pain or the muscular pain gets worse, which is very much against what we see in this inflammatory back pain. So you can clearly see that it is easy enough to differentiate between the inflammatory pain versus the mechanical pain. And these are different criteria used to differentiate, to formally diagnose, for example, patient with inflammatory back pain. We are looking more at the far right side of that, which is called the IBB experts ASAS criteria, for example. In these one, out of those 5, so if somebody fulfills 4 out of 5, we label this patient as having inflammatory back pain. And you can see it takes only 20-30 seconds, for example. The age of onset is less than 45, insidious onset of the back pain, and improvement with exercise, and there's no improvement with rest, and the pain at nighttime. So if somebody fulfills these 4 out of 5, you can confidently say that that patient has got inflammatory back pain, which is, as I mentioned earlier, is the hallmark, is the chief symptom of spondyloarthritis. So spondyloarthritis is an umbrella term, which is used to sort of, it encompasses various different subset of inflammatory arthritis. For example, when you talk of the pediatric population, we're talking about enthesitis-related arthritis and psoriatic arthritis, but in adult population, there's a lot of other types of arthritis. And there's a reason why they are clumped up into one big group. For example, there's a much more highly prevalent HLA-B27, there's enthesitis there, there's an axial disease, meaning the spinal disease, which is much more predominant compared to the peripheral joint symptoms. And also there are predominant extra-articular manifestation manifesting as the uveitis, for example, and so on. And it is classically seronegative arthritis, means the rheumatoid factor and so on is negative. So enthesitis is another very important and the predominant symptom which we see in this patient with the spondyloarthritis. And what simply it is, if we look at entheses, for example, the entheses are the sites where our joint capsules, ligaments, and the tendons are attached onto the bone. So these are the entheses. So when there is an inflammation on those sites, it's called enthesitis. So that is very simple as that. So usually, of course, there are hundreds and hundreds of entheses areas in our body, but we are predominantly sort of bothered about Achilles tendonitis, for example, the medial side of the knees, and the lateral epicondyles, which are the main predominant entheses which are affected in spondyloarthritis. For example, in these one, what we're looking at, the left side is the Achilles tendon, that where there was inflammation, and this is called enthesophyte, means the enthesial inflammation area gradually after inflammation has become ossified into that tubercle. And that's the same thing which we see in our patient with the plantar fasciitis, which they call spur, for example. And in the lower down, we're looking at the MRI images where there's a predominant and the stark inflammation at the insertion of the Achilles tendon. So why it is important, why not looking at the subset, for example, of the inflammatory arthritis? We are concerned, of course, is the spondyloarthritis, as I said, is the umbrella term, because sometimes in the initial disease course, the symptoms might not really fulfill any of the major criteria, because the patient might be having some enthesitis there with only one joint affected. So really that does not fulfill any particular disease characteristics or the diagnostic criteria. But clearly you can see that that patient would fulfill this broad category of spondyloarthritis. So that's why it helps us to make an earlier diagnosis. In other words, what I tell to my fellows is it gives you a smell, it gives you a feel that what big particular disease characteristics this patient belongs to. So there is a major sort of the advancement in the disease management and all this, but the diagnostic and the major sort of the heartache leaves for rheumatologists is the delay to diagnosis. Historically, there has been 8 to 9 years of the diagnostic delay, unfortunately, before they get diagnosed. But in last, again, after even all the advancements and all the different referral algorithms being developed, but unfortunately to date, the diagnostic delay remains unfortunately still 4 to 5 years. So this was one of our studies when I was in Dublin. So it clearly gives you the patient journey. For example, what happens to the patient before they get finally diagnosed with this spondyloarthritis. In this particular 2 prospective studies, what we found out was that 62% and 72% in our second cohort, the patients were already walking around with these symptoms and knocking on the doors of different disciplines, for example, the physiotherapists, general practitioners, and different. So the patients are already walking around with their symptoms, knocking, as I mentioned, doors of different other disciplines, but actually nobody is making sense of their symptoms. So that leads to significant diagnostic delay in these patients. So that's why it's very important to highlight that these patients are not asymptomatic. These are patients are not sitting at home. These patients are actually symptomatic and walking around, but actually their delay, unfortunately, is happening because of medical community fault rather than their fault. So what are the barriers to this delayed diagnosis? One is, of course, is the back pain. Why? Because who doesn't have the back pain? Back pain is very common. So it's very easily ignored, in other words. For the young people, for example, it is mentioned that, oh, they might be sitting in front of the computers for so long and so on. So that's why it's easily blamed to other things rather than actual disease process. But the other problem is also about this diagnostic criteria, because in adults, what it is told is that somebody has to have an X-ray damage happen before you label them with ankylosing spondylitis, along with the limitation of the movements. So this is the standard diagnostic criteria. So in this one, what I've highlighted is that you have to have an X-ray abnormal evidence before you label somebody with ankylosing spondylitis. But clearly what we have seen in last at least 1 decade is that the patients are getting, for example, an MRI more common. For example, in this one, what we are seeing is the middle X-ray, for example, that the patient, the X-ray of sacroiliac joint in the middle, this is absolutely normal looking sacroiliac joint. This young person having the back pain, but the normal X-rays, but the same patient at the same time when he had an MRI done, what it clearly showing is that there is a significant bilateral bone marrow edema, means there's an inflammation happening being elicited by the MRI scans, but unfortunately the X-ray is normal. And the same patient, of course, if you delay the diagnosis, do not treat that patient. And what eventually is going to happen, what we're seeing on the left-hand side is that the X-ray is going to be abnormal after a few years. And at that stage, unfortunately, everybody will be very happy to diagnose them that this patient has ankylosing spondylitis or spondyloarthritis, in other words. But unfortunately, by that time, you would have missed the boat in a broader sense. So in other words, if you're looking at just X-ray, abnormal X-rays to diagnose and elicit these particular diagnoses, we are looking at just the tip of the iceberg, and we're absolutely missing out on what is happening before the X-ray abnormalities are happening. And this is what we call pre-radiographic stage, or formally what we call now is the non-radiographic stage of spondyloarthritis. So this is now, as I mentioned, is the formally recognized sub-stage of a subset of spondyloarthritis, in other words. But again, this is a continuum of the same process, that you're going to have a back pain, abnormal MRIs, again, the disease process continues, and then there's be abnormal X-rays happening. For most of the patients, not all, but majority of the patient, there's going to be this particular continuum of the disease process. But it's very important to highlight, if you look at these, for example, the how long it takes before the X-ray becomes abnormal. So what you're seeing here is very importantly that after 2 years of back pain, only 11% of the patient are going to have abnormal X-rays, and 5 to 10 years of the disease still going on, and only 1/4 of the patients are going to have abnormal X-rays. So it's very important, again, I'm highlighting this again and again, is that X-rays take much, much longer before they become abnormal. So we should not be looking at the radiographic damage only. We should be listing and focusing on the symptoms. So this is a spectrum of spondyloarthritis. We're starting from the left-hand side. For example, the patient have the back pain. At the very, very early stage, the MRI can be normal even, absolutely normal. But gradually, of course, the MRI become positive. And then later on, with the more longevity or the disease continuation is happening, there's going to be abnormal X-rays of sacroiliac joints, and gradually they're going to be spinal involvement and the syndesmophytes and so on. So if you look at the progression, for example, there has been a lot of cross-section studies, longitudinal studies. Just for the shortage of time, I'm just going to skip all those studies. So what they're absolutely showing is that the longer the disease process, the more X-ray evidence what we are seeing, and the shorter the disease process, the X-rays what we see, they are normal, but the abnormal MRI still are happening. So in other words, the progression from non-radiographic spondyloarthritis to full-blown abnormal X-rays is the time-dependent critical event, and that unfortunately is the medical community fault in case if the patient still continues and have a regular follow-up. So this is what since 2009, we are using this as a classification and mostly for diagnostic purposes as well. And based on these ones, we can diagnose a patient with spondyloarthritis even with the normal X-rays, even with the normal MRIs, but with the right clinical history. And also significantly important are the associated features, for example, the uveitis, the psoriasis, the family history of inflammatory arthritis, and so on. So on those bases, we can easily diagnose a patient at a much, much early stage. So how we investigate? So as I mentioned again, the appreciation of inflammatory back pain is the most important step in diagnosing spondyloarthritis, and then is the associated features of spondyloarthritis. And we know the imaging studies, of course we do, but again, there are also caveats of these imaging studies. As I mentioned, the X-rays take much longer. HLA-B27 is not one of my favorite one. I usually do not request, because not only this is very, very expensive, but also at the same time, we should be diagnosing patient not on the genetic, but more on the clinical grounds. And again, it's very important to highlight that there's absolutely no lab test which is diagnostic of spondyloarthritis. Raised inflammatory markers, we see around 50% of the patients. So the patient can have very roaringly active disease, but the normal CRP and normal ESR is very important to understand. And again, of course, as I mentioned, the X-rays can be normal. So there's no diagnostic test, and we are down to the same as the clinical means. The patient is sitting in front of you, giving the right history, and that is the vital as regards going forward. So just a few words about HLA-B27. We know that roughly around 7% of the population gonna have a normal in the population HLA-B27 positivity. Only 1 to 2% or maximum 3% of the patients who are going to be HLA-B27 positive will develop ankylosing spondylitis or spondyloarthritis. Means this is not all that we need this genetic particular marker, but also important is the family history. For example, if in my family, even his first degree relative or second degree relative of mine one, for example, is HLA-B27 positive with spondyloarthritis, then if I turn out to be HLA-B27 positive, my risk of developing spondyloarthritis goes up to 21% compared to another person who does not have any HLA-B27 positive spondylitis in their family, which is only 3%. So the family history of spondyloarthritis and HLA-B27 positivity, of course, has got significant relevance. So that's why I do not, I would request that do not request HLA-B27 positive routinely, because not only this is also expensive, but it causes a lot of confusions, because HLA-B27 positivity in the normal population is 7 to 8%. So let's focus on our main talk. So this was just to give you a flavor of spondyloarthritis in general, that what, of course, the pediatric rheumatology colleagues can learn from spondyloarthritis from our part. So we know that this is the initial or the earlier classification criteria when we talk of the JIA, for example. Unfortunately, this was the one that I really disliked, because this was quite sort of confusing, in other words, and it's very difficult to remember all those different subsets. So in this spondyloarthritis, where would lie in is, which I've highlighted here, is the enthesitis-related arthritis and psoriatic arthritis. These are the two main subsets of juvenile spondyloarthritis. So compared to, for example, the adults, there's a lot of different other subsets. So in juvenile population, we only concerned about enthesitis-related arthritis and psoriatic arthritis being the main subsets of juvenile spondyloarthritis. But the good news is that in lately, there has been a significant focus or the change of focus that this particular classification of GIA should be revised based on their adult counterparts, because most of these patients, not all, but like significant majority, going to have some form of inflammatory arthritis in their adulthood. So that's why there is this particular focus is that their counterparts in the adult, there should be some sort of synergy there. So that's why they have now, there's a proposal there. It's not fully agreed upon. So these are the sort of, if you like, in discussion at this stage is the systemic GIA, for example, is counterpart in the adult, but we see the adult onset still disease. Rheumatoid factor positive GIA is what we see in adults, seropositive rheumatoid arthritis, and enthesitis related spondylitis, and all those into one big group called spondyloarthritis and so on. So I think this is going to make much more sense for adults as well, and of course for the pediatric rheumatology colleagues as well. So as I mentioned, in juvenile spondyloarthritis, these are the two main subset, ERA and psoriatic arthritis subset. This particular picture gives the overall frequency of ERA and psoriatic arthritis in the overall GIA category. And what we are seeing here is there's significant differences as regard the prevalence of these two subsets. For example, if you look at in our Asian population, there is a 30%, for example, prevalence or the frequency of ERA in the overall GIA population. And in the same study in Italy, it was only 5% of ERA in their country. So there is a significant differences when it comes to frequency of ERA and psoriatic arthritis. And if you look at, for example, the prevalence studies in the US and Europe, for example, in the European population, it is shown the prevalence of for example, the whole psoriatic arthritis and ERA is about 5 to 6 per 100,000 population. And the USA, Canada is 6 to 9 cases per 100,000 population. So it's not that common, if you like. So this is how we diagnose enthesitis-related arthritis. This is a much bigger group. That's why, of course, it's much more common when we look at, for example, peripheral. So it's a different combination of peripheral arthritis, enthesitis, and the spinal involvement. I'm not going to go in detail just because, unfortunately, we're already a little bit short of time. So these are the different sort of, as I mentioned, the combinations we use, and then we diagnose somebody with enthesitis-related arthritis. There are very stark features of ERA, for example. This is usually common in the early age, for example, 10 to 12, 10 to 15 years, and it's much more common in the males. We see the enthesitis and, of course, the arthritis there. The uveitis involvement is very much different. What we see in psoriatic arthritis, it's typical of acute anterior uveitis. This is the one what we see in our adult population associated with ankylosing spondylitis, for example. So these are very sort of typical features what we see in enthesitis-related arthritis. However, in psoriatic arthritis, when you talk of in juvenile population, it has got a bimodal age of onset. What I mean from that is the one subset presents a lot earlier in age, for example, at the age of 2 to 3 years. And these are the patients typically who are ANA positive, they have dactylitis, small joint involvement, and they have ANA positivity. And the uveitis, when it comes with this particular subset, is more of chronic uveitis rather than an acute anterior uveitis. And the later onset when it comes of psoriatic arthritis is very much similar to what we see in our adults population with the equal gender distribution and so on. But the important thing for pediatric from end is that it usually happens in a lot earlier in the age, and these are usually ANA positive. So this was original how we diagnose psoriatic arthritis. Is a simple, for example, somebody having psoriasis and arthritis, or somebody having arthritis only, but they have at least 2 of those features. For example, psoriasis in a first-degree relative, there is a nail pitting or the nail usually psoriatic changes, or dactylitis. So in those 3 features, if the 2 are positive, along with an arthritis happening, you can confidently diagnose that patient with the juvenile psoriatic arthritis. So comorbidities we see very common in the adult population, and the same has been reflected in the longitudinal studies in the younger population, is that the depression and IBD and the uveitis, the usual comorbidities which are associated with these ERA and psoriatic arthritis. And psoriatic arthritis is, of course, these comorbidities are more common than enthesitis-related arthritis. So if you look at the genetic association, for example, in enthesitis-related arthritis is very much similar to, again, our adult counterpart, which we name as ankylosing spondylitis, means HLA-B27 positivity is much more common, but also ERAP1, for example, is much more common in these patients. So there is a significant genetic similarities of ERA with their adults disease of ankylosing spondylitis. And the same has been shown with the psoriatic arthritis. For example, the genetic studies is very much similar to what our studies have shown is, for example, HLA-C0602 and also HLA-B27. So very much similar to the adults, for example, the population. Of course, there are differences. There are subtle new signals which have been detected in the younger patients compared to the adults one, but overall, the major, for example, the genetic alleles, there are significant similarities there. So let's look at the burden of disease. We know about the delay to diagnosis, but we looked at the adult counterparts, for example, it's a number of years, and the same has been shown, for example, in the childhood as well, that the mean age, for example, if you look at the psoriatic arthritis, there's a mean delay of diagnosis is up to 4 years. For ERA, of course, the patient, for example, if somebody has got peripheral arthritis, of course, they get diagnosed much more quicker. But if somebody has got more predominant spinal disease, these are the patients where there is a significant delay to diagnosis, unfortunately. If we look at the patient-reported outcome measures in the patients with the juvenile idiopathic arthritis as a whole group, for example, you'll be amazed to hear that psoriatic arthritis and enthesitis-related arthritis has got one of the worst pain and health-related quality of life compared to the other subsets. Means there's a significant, it has got an impact on young patients with the ERA and psoriatic arthritis life. So if you look at the risk factors which are associated with the poor outcomes, for example, one, of course, clearly has shown that in the countries which have got low socioeconomic, that has got background, has got a significant impact, along with somebody who comes in with already having sacroiliitis present when they come to the rheumatologist, then unfortunately they have got a worse outcome. And the same is with enthesitis, somebody having ongoing enthesitis. So these are the three main ones which has been noted to have more long-term poor outcomes in these patients. So this is a very sort of important, very sort of relevant study, one of the best ones that you can think of. So this particular study, very big number of patients being actually prospective followed after 18 years. So after 18 years of the disease onset, so it's very important to understand that unfortunately 23% of the psoriatic arthritis and 14% of the patient with enthesitis-related arthritis are still going to have articular damage happening at that stage. And unfortunately, and these are the studies which have been happening in the best centers. I'm talking about the Europe and the North America. What they're showing is after 18 years of the disease onset, unfortunately, 65% of the patient with enthesitis-related arthritis and more than 50% of the patient with the psoriatic arthritis still have got active disease. So clearly, for all of us, it's very important to understand. I must say, like when I started my medical college, we used to think that this psoriatic arthritis is going to be just for their childhood only. When they're going to grow up, when they're going to go into their adult age, probably this particular disease is going to go away. But this particular study has shown that this is not the case. The majority of the patients, unfortunately, after 18 years of the disease, they still have got active disease. So there's a lot that we need to do for these patients. So what are the treatment options we have? So these are the, like, of course, we start with NSAIDs when we predominantly talking about the spinal pain, for example. Steroids remain, of course, one of the bread and butter for us as well. But initially, when we talking about the induction, but naturally we need to, this is one of the drugs which is absolutely very difficult, of course, for in the juvenile population because of the adverse outcomes. What are those is, we know we have seen patients with, for example, AVN happening, their growth, for example, stopped because of the steroids. So that's why it's very important that we need to stop these medicines as soon as possible. And of course, we use conventional synthetic DMARDs, for example, the methotrexate, leflunomide, slazodine, and so on in different combinations, more for predominantly peripheral joint disease, for example, the knee and so on. And we use biologic DMARDs. Now, personally, if you ask me, I'm much more, will be more in favor of that, introducing biologic DMARDs at a much earlier age in the younger population than in the adult population. So these are the recommendations, how we go about treating these patients with enthesitis and sacroiliitis. For example, in the left-hand side is enthesitis. So it's very simple. We start with NSAID. Of course, if NSAID is not usually enough, then we move on to the addition of any biologic treatment, for example, anti-TNF or secukinumab, IL-17 inhibitors, and we use the bridging therapy with the steroids. And the same is with the sacroiliitis. We start with NSAIDs, and at times we use some sulfasalazine as well, because there has been some initial studies of using sulfasalazine having some improvement of the spinal symptoms. But again, there is no high quality studies in favor of sulfasalazine, but as is mentioned, there are some earlier studies. So we do use those sort of sulfasalazine, for example, predominantly for spinal disease. But if somebody has got peripheral joint disease, then definitely we use methotrexate. So treat to target is very important, again, in the adult population, but also now we are talking more about the younger population as well. In simple words, treat to target is that we sit down with the patient and come up with the common targets, in other words. So again, being a treating, for example, rheumatologist or a physician, I might be having one very, for example, different objectives. Of course, I really want that the patient needs to go on this particular treatment. I really want 100% for the patient, and might not be possible for that particular family and the patient. So you really need to be talking to the patient, come to the common grounds, come to the common objectives. What are those? And then work around those ones. And that is only possible, of course, with the regular follow-up and so on. So the anti-TNFs used are the adalimumab, etanercept. Golimumab is a license, but unfortunately, we don't have the availability of this particular drug in Pakistan. This is the one particular study which got published in December, just gone. And this was the basis of for FDA approval of secukinumab IL-17 for juvenile spondyloarthritis. Again, but in simple words, I'm not going to go in that detail, but in simple words, what you want to see is that 53% of the patients who went on being treated with this particular secukinumab, which is once a month injection, there was 53% reduction in the risk of flare versus placebo. And in psoriatic arthritis, 85% of the reduction of flare happened with this particular biologic. And this is now being used, and we have a number of patients using this particular secukinumab. So early initiation, of course, it's needless to say that the earlier you treat, the better outcomes you get. And this has been formally included in the guidelines from Arthritis Foundation and the ACR guidelines that we should be initiating the DMARDs much earlier age. And why is that important? Not only we know from some studies, but this is the study on the highlighted on the left-hand side. And the graph is that this particular study, including more than 700 patients with the juvenile idiopathic arthritis. And what you're seeing here is that the longer the delay happening of introducing the biologic DMARD, the lesser the chances are that these patients ever be able to be off medication. Because for rheumatologists, so the best objective or the best sort of the success, if we can think of, is that the patient went on treatment and we have been able to take them off medication. In other words, achieving remission without drugs is the major sort of the success, in other words. And in this particular study has shown that if you introduce biologic within 2 years of disease onset, around 20% of the patient will be taken off drugs eventually, and they will be maintained their remission. And if there is the delay of 2 to 5 years of introducing biologic, only 10% of the patient will be able to ever off these drugs. And if there is a more than 5 years of the delay in introducing biologic, for example, only 5% or 95% of the patient, in other words, will end up using medication for years and years to come. So it's just again mentioning, highlighting about the same thing, is that the proportion of patients with active disease, despite DMARDs and the biologic DMARDs, unfortunately, as I highlighted this particular study earlier as well, the significant majority of these patients, unfortunately, continue to have these I'm just going to skip this just for the short of time. So in summary, ERA and the psoriatic arthritis, as I mentioned, these are the two chief subtypes of juvenile idiopathic arthritis or juvenile spondyloarthritis. In other words, it is not that common. These are absolutely symptomatic patients. As I mentioned, their patient-reported outcome years are one of the worst one in the juvenile idiopathic arthritis, and the burden of disease is significant. And we will be highlighting a few case stories as well, and which you'll be very absolutely delighted to hear that when the patients go on these particular targeted treatments, that how quickly actually their disease and their life gets revolutionized and they get the better outcomes. So now we're going to move on to our second session. It is the patient journey in their own words. So I'm very thankful to our two young patients who we have just recently seen. And these are not our historic patients. These are just seen in last only couple of weeks ago. So I'm going to ask them again, we'll be asking them a couple of questions. Initially, I'm going to present their brief case scenarios. So from the medical end as well, you'll be able to see actually what their story is. So let's start with our first patient. So this is our case one. So this is a 13-year-old young girl. I hope you can see her there. It's a little bit from a distance. She's sitting with her mom. Please. So this is a young girl. So I'll tell you a little bit of story about her. So she's a 13-year-old young girl from Salkot. She presented with about 1 year history of lower back pain and the left leg discomfort. She was using wheelchair to mobilize. And literally when her mom came to us, she was being lifted and carried on their arms when she came to us. She was off school for 6 months. And when she came to us, of course, she was recommended at that stage having left hip surgery. And we were unclear what was the reason why she was recommended as regards the surgery. So these are her MRI scans. So I'm not going to go in detail a lot there. We'll be discussing on the MRI scans in our next session there. But what we found out was that in the MRI scans, there was a very sort of predominant, very sort of intense inflammation happening in her left hip, also in the right hip as well, and the sacroiliac joints, along with the significant bursitis, trochanteric bursitis happening in this particular case. So there was very, as I said, the hyper intense signals happening in this particular case. So it was very obvious that this young girl is suffering from juvenile spondyloarthritis and was a very aggressive disease that within 1 year, she was literally wheelchair bound and her disease was progressing too fast. So she was seen for the first time on 10th of January this year, 2022. She was started on our standard treatment along with, of course, the biologics. She got admitted for about a day or two plus minus, and then she was discharged. And then she was reviewed again twice in February as well, and in a couple of days earlier as well. And literally, it was an absolute pleasure when we saw her within 4 weeks when she came on 14th of February, that she was absolutely 100% asymptomatic, and she was able to absolutely walk around normally. She was even able to sit down on the floor, and she started even going to school, which she has not been able to go for a last number of months. So it was, as I mentioned there as well, it was absolute priceless to see, because when her mom came to us for the first time, she was literally in tears at that time as well. But when she came to us within 4 weeks time, plus minus, so she was also in tears, but this time the tears were for a different reason. It was predominantly, she was so much thankful that completely her whole family's life is changed because they were too much concerned about her daughter. So literally within 4 weeks time, her disease, her life has absolutely changed, and she was absolutely a normal young girl, walking around, running around, able to sit down even on the ground as well, and started to go to school. So I'm just going to, I hope you can see her there now. She's sitting here. So I'm just going to, just for all of us. So firstly, Sabah, Assalamu alaikum. Thank you very much. आप लोग आए हैं, बहुत शुक्रिया. थोड़ी देर पहले भी आए थे आप, चंद हफ्ते पहले. So again, we are all very thankful कि आप लोग आए हैं. तो थोड़ी सी अगर आप, जाहिर है जैसे मैंने आपको कल भी बताया था कि ये सारे हम लोग डॉक्टर्स हैं, सारे एक दूसरे को पढ़ाने और सिखाने की कोशिश कर रहे हैं ताकि ज़ाहिर है आप जैसे और बच्चे इफेक्ट ना हो, ताकि दोबारा जिस तरह आप लोग भी ज़ाहिर है. तो थोड़ा सा आपने मुझे बताना है, सब आपने भी और आपकी वालदा ने भी, कि अपनी अलामात के बारे में, कि एक साल पहले जब ये शुरू हुई तो क्या क्या अलामात थी, और पूरे एक साल में जब तक हमारे पास आए तो अलामात के बारे में बस पहले ज़रा बता दें.
अस्सलाम वालेकुम, मेरा नाम सबा जमील है, मैं 9th क्लास में पढ़ती हूँ. मुझे एक साल से लेफ्ट लेग पे बहुत ज़्यादा पेन थी, जिसकी वजह से मैं चल नहीं थी सकती और स्कूल भी नहीं थी जा सकती. व्हील चेयर पर मैं बैठती थी और 6 माह से मैं स्कूल भी नहीं थी जा सकती. मुझे बहुत ज़्यादा पेन था, रात को मैं सो भी नहीं थी सकती, सुबह मुझसे उठा भी नहीं था जाता, मैं लेटी रहती थी और वॉशरूम भी नहीं थी जा सकती. मुझे बहुत ज़्यादा पेन था.
जी जी बेटा बताएं, शाबाश. हाँ, तो आप चल फिर नहीं सकते थे एक साल से हैं?
एक साल से बहुत ज़्यादा पेन था.
अच्छा, तो जी आपकी वालदा थोड़ी सी अगर बताना चाहें कुछ.
अस्सलाम वालेकुम, मैं सबा की मामा हूँ. एक साल से मेरी बच्ची को बहुत ज़्यादा तकलीफ थी और इस तकलीफ इस हद तक थी कि मैं अपनी बेटी को अपने हाथों पे उठा के वॉशरूम लेके जाती थी. चलना फिरना इसका बहुत ज़्यादा मुश्किल था. ये व्हील चेयर और स्टिक यूज़ करती थी. तो ये सारी रात तकलीफ से सो नहीं सकती थी. सियालकोट में कोई ऐसा हॉस्पिटल नहीं था जो मैंने नहीं छोड़ा. दिन रात मेहनत की, बहुत ज़्यादा दौड़ें लगाई, लेकिन मेरी बच्ची को कोई फ़र्क नहीं पड़ा. फिर उसके बाद मैं लाहौर आई, फातिमा मेमोरियल हॉस्पिटल, डॉक्टर हारून साहब के पास, और अल्हम्दुलिल्लाह माशाल्लाह उनके ट्रीटमेंट से एक माह में मेरी बच्ची चलने के काबिल हो गई, खुद वॉशरूम जाने लगी, स्कूल जाने लगी, खेल कूद में हिस्सा लेने लगी. तो इसकी जो तकलीफ थी बहुत ज़्यादा कम हो गई. तो ये शुक्र अल्लाह पाक का कि अल्लाह पाक ने हमें हारून साहब के पास भेजा. तो माशाल्लाह मेरी बच्ची बहुत ज़्यादा बेहतर है, तमाम एक्टिविटीज़ में हिस्सा लेती है और तकलीफ वगैरह ख़त्म हो गई है इसकी. सियालकोट वालों ने तो बहुत इलाज कर दिया था. वो बहुत ज़्यादा मसाइल बताए थे कि टिश्यू ख़त्म हो गए इसकी वेन ब्लॉक हो गई है. लेकिन ये है कि अल्हम्दुलिल्लाह जब हम इधर आए तो वो जो तमाम बातें पिछली थी वो सारी गलत हुई, और अल्लाह पाक का शुक्र है कि अब मेरी बच्ची माशाल्लाह बहुत बेहतर है, बहुत ज़्यादा बेहतर है. मैं शुक्र अदा करती हूँ पहले नंबर पे अल्लाह ताला का, उसके बाद डॉक्टर हारून साहब. मेरी बच्ची माशाल्लाह बहुत बेहतर है.
थैंक यू. कोई मैसेज देना चाहेंगे जो डॉक्टर्स को,
मैसेज ये देना
हमें,
चाहते हैं
हमारे लिए आप क्या कहना चाहेंगे
कि
डॉक्टर्स के लिए?
जितने बीमार इस तरह के बच्चे हैं जहाँ भी हैं, अल्लाह पाक उनको डॉक्टर हारून साहब की तरफ लेके आए ताकि वो सेहतयाब हों. अल्लाह पाक उनको सेहत दे और सेहतयाब हो कि यहाँ से निकलें और दुआएं दें. तो हम लोग जो दूर दराज से आते हैं, बहुत ज़्यादा गाँव के भी लोग मोहल्ले से आते हैं, जो गाँव साइड से, सियालकोट हमारा गाँव साइड ही है. तो लेकिन उधर के जो डॉक्टर्स हैं वो कुछ उन्होंने गाइड नहीं किया. लेकिन जिधर जिधर से भी इस तरह के बीमार बच्चे हैं, अल्लाह पाक उनको ये रास्ता दिखाए, आए और अपना इलाज इधर से करवाएं. शुक्र अल्लाह पाक का, और उसके बाद डॉक्टर साहब का शुक्र है कि मेरी बच्ची माशाल्लाह बहुत बेहतर है.
अभी किसी ने क्वेश्चन किया है जी इधर से कि एक्सपेंस, इस ज़ाहिर है ड्रग्स एक्सपेंसिव होती हैं, लेकिन पाकिस्तान में एक बड़ी खूबसूरती है कि यहाँ आपको बहुत ज़्यादा लोग मिल जाते हैं जो हेल्प करने के लिए. लिटरली देयर लुकिंग फॉर रीजंस. पाकिस्तान में मुझे तकरीबन 4 साल हो गए और ये मेरा एक्सपीरियंस नहीं है, जो जितने भी मेरे कॉलीग्स हैं, अगर जब लोग वो कहते हैं ना अगर आपको कोई रास्ता ढूंढना पता हो कि तो मिल ही जाता है रास्ता। When there is a will, there is a way, वो पुरानी जो एक है ना, तो इसलिए there is a lot of donors around, absolutely big number of donors around। तो अल्हम्दुलिल्लाह इनके लिए भी बड़े donors मिल गए थे हमें, किसी को मुझे जाके कहना नहीं पड़ा। So बड़ी expensive ज़ाहिर ड्रग्स होती हैं, but लेकिन we have got alhamdulillah enough funds, we are sponsoring those biologics to these patients। There are number of patients, बल्कि अल्हम्दुलिल्लाह हमारे फातिमा मेमोरियल में there are well more than 100 patients जो इन biologics पे और बड़े ड्रग्स पे हैं। तो इसलिए फंडिंग इज नॉट एन इशू। इंपॉर्टेंट चीज़ यही होती है कि ज़ाहिर है कोई ना कोई डायरेक्शन और प्रॉपर डायग्नोसिस हो जाए, प्रॉपर मैनेजमेंट प्लान जो है इन प्लेस हो जाए। सो दैट इज़ अ मेजर सॉर्ट ऑफ सक्सेस। तो थैंक यू वेरी मच अगेन। मैं सिर्फ आपको इनको ज़हमत इसलिए दी थी फॉर ऑल ऑफ अस, फॉर आवर सॉर्ट ऑफ कॉलीग्स एज वेल, टू लर्न फ्रॉम दिस पर्टिकुलर फैमिली कि अल्हम्दुलिल्लाह कि कितना ज़्यादा ज़ाहिर सॉर्ट ऑफ ये इम्पैक्ट था इस पर्टिकुलर डिजीज़ का, नॉट ओनली फॉर दैट यंग गर्ल हु वाज लिटरली was on wheelchair, and so within 4 weeks she was absolutely 100% asymptomatic। So proper again diagnosis, proper disease management plan in place, that's all what is needed for this particular young girl who's only 13। And of course we can absolutely avoid the disability for rest of her life and also for her family as well। So thank you very much again। बहुत शुक्रिया आप लोगों के आने का।
आप खाएंगे पूरी अपनी तरह नहीं खाएं, जबरदस्ती खाएं। देगा आपको भी, आप मैंने नहीं खानी, मैंने उधर खाना है।
Right. So we're going to move on to our second patient. So this is our, now talking about our second patient. So this is Mr. Sufyan. He's a 17 years old male. So his first visit with us was on 29th of February, 2022. He came with an 8 years history of arthralgia and lower back pain. So it is again quite heartbreaking to hear this, that he was taking off school as he could not cope with the daily travel and the studies because of the pains of the back and the legs and so on. So literally he was not able to go to school, and he was literally by his parents, of course, he was taken off school. And then he was sent to madrasa purely because of the reason it was considered that, okay, for the whole day he will be sitting and not doing much traveling and all this. So he was sent to madrasa. But unfortunately, again, it backfired because, of course, in the madrasas, he was not able to sit down or in the ground and all this for a longer period of time. So again, it doubled up his symptoms. So he was again taken off from madrasa as well. So he had to quit madrasa, in other words. He was having significant difficulty, which was progressing. And of course, his body weight was growing, and he was 102 kilograms in weight when he came to us. So when we looked at his previous records, so he almost always had persistently raised inflammatory marker for last number of years. His, of course, inflammatory markers were high, but his rheumatoid factor and anti-CCPs were negative. And he had been on a different courses of antibiotics, and you name it, which particular discipline in the periphery he has not been to. And when on the first day when he came to us, as I mentioned the date on 29th of February, he had bilateral knees and ankle synovitis there. There were bilateral midfoot synovitis. There was a right second digital dactylitis there. There was a significantly reduced range of movements of the cervical spine and the lumbar spine. And we got him admitted the same day, and there was synovitis on ultrasound of the ankles and the midfoot small joints. So it was very obvious that this patient has got enthesitis related arthritis, and X-ray of his spine. This is his X-ray when it came. So on the right-hand side, of course, is looking at the whole spine and the sacroiliac. The right one is predominantly on the sacroiliac joints. And what we are seeing here is that there's a significant bilateral sacroiliitis. There are big erosions sitting there. There's a lot of sclerosis there. Means in simple words that this patient's had got sacroiliitis, being active sacroiliitis, and this was not new, means this particular disease process was going on for a number of years. So he was started again on the standard treatment. And again, this particular case was also that, alhamdulillah, within 4 weeks, he was absolutely asymptomatic when we saw him only, I think it was 2 weeks ago or thereabouts, and he was able to mobilize independently. He was absolutely pain and stiffness free. There was slight limitation of range of movements of the spine, of course, which was persistent because there was having, and also biomechanical gait issues due to feet deformities, which happened because we're talking about the 8 years of particular disease onset. So let's talk to the patient there. I hope you can see Sufyan. Thank you very much, Sufyan. आप लोग आए और इनके साथ इनके पेरेंट हैं. तो बेटा आपने भी थोड़ा सा हमें बताना है अपनी बीमारी के बारे में, अपनी अलामात के बारे में, कि आपकी अलामात जो चल रही थी 8 साल से, जरा थोड़ा सा ब्रीफ हमें और हमारे
अस्सलाम वालेकुम रहमतुल्लाह. 8 साल पहले मुझे पाँव पे दर्द शुरू हुई थी, तो वहाँ से घुटनों पे आ गई, घुटनों से यहाँ पे कंधों पे आ गई, यहाँ से बहुत ज़्यादा दर्द शुरू हो गई थी. तो मुझसे बेड से भी उठने नहीं होता था, इतनी शदीद दर्द थी. तो वहाँ से मैंने स्कूल 7वीं में पढ़ता था, वहाँ से फिर छोड़ा, फिर मदरसे दाखिला लिया. वहाँ पे भी नीचे बैठ के आपको पता पढ़ना होता है. वो कारी साहब कहते हैं कि आप ठीक हो गए हैं, फिर दाखिला ले लेना. फिर वहाँ से भी 2-3 साल पहले छोड़ दिया. तो ऐसे ही दर्द बहुत है.
तो आप थोड़ा सा हमें बताएं कि क्या क्या आपका इलाज होता रहा, कहाँ कहाँ आप इस बीमारी के लिए जाते हैं?
गुजरात में तकरीबन सब डॉक्टरों को चेक करवाया था.
तो क्या कहते थे कि
पेन किलर वगैरह दे देते थे, कहते थे ये मसला है, कोई नहीं है इतना.
तो अभी कैसी तबीयत है बेटा आपकी?
अब बेहतरीन, अल्हम्दुलिल्लाह बेहतरीन.
अभी कोई अलामत हैं अभी आपको? कोई दर्द, कोई अकड़ाव वगैरह होता हो जो पहले आपको सुबह उठ के होता था, कोई अकड़ाव वो हो?
बेहतर है बहुत.
रात को आपको कोई मसला होता हो सोते हुए, जो पहले आपको रात को नींद नहीं आती
पहले
थी?
बहुत ज्यादा थी, पहले नींद भी नहीं थी आती. अब अल्हम्दुलिल्लाह ठीक है बहुत.
चलना फिरना आपका कैसा है अब?
चलना फिरना
ठीक, स्कूल जाना चाहेंगे अब?
जी इंशाल्लाह.
जबरदस्त जबरदस्त. थैंक यू वेरी मच. थैंक यू. अच्छा, आपके पेरेंट जो कुछ कहना चाहें, अगर कुछ ऐड करना चाहें. ये जरा माइक दे दें.
गुजरात में कोई डॉक्टर नहीं छोड़ा,
करीब कर.
प्राइवेट भी नहीं छोड़ा, खारिया में गया, लाले मुंह से में गए, कोई फर्क नहीं पड़ा. और मेडिकल स्पेशलिस्ट डॉक्टर के पास भी कोई वो बोलते हैं नफसाती मरीज हो गए, इसको ये ठीक है, ये बहाना कर रहा है, ऐसे कर देते थे. और डिस्प्रिन की गोली देते थे, डिस्प्रिन की गोली पानी में डाल कर पियो, ठीक हो जाए. ये बहुत आपकी मेहरबानी है और अल्लाह की मेहरबानी है. पहले अल्लाह की मेहरबानी, बाद में डॉक्टर साहब अरुण साहब की मेहरबानी है. बच्चे को आपका लाख लाख बार शुक्र है, अल्लाह का बहुत बहुत शुक्र है कि मेरे बच्चे को तंदुरुस्त किया है. अल्लाह का बहुत बहुत लाख लाख शुक्र है. और अरुण साहब की बहुत बहुत मेहरबानी है तो मेरे बच्चे को ठीक किया है.
Thank you. Thank you. So I didn't hear this earlier. So again, this was the last thing that we unfortunately do, and that is to blame patients saying that ye nafsiyati ho gaye. So it's very heartbreaking to hear that not only that he's being crippled, not only that he's being disabled, not only that he has not been able to go to any school or madrasas, rather being told that he has become psychologically having issues. So this is again very heartbreaking that alhamdulillah, I hope you can see him walking around. Zara iski tarah tasveer dikha denge, zara the way he's walking. So he's absolutely normal walking. I hope you can see. Sufyan, zara chal ke dikhayenge beta. इधर ही आ जाए इनकी तरफ, कैमरे की तरफ आ जाए. So apologies, we are not like professional photographers or camera people or something. We are all trying to help each other. So you can see him, he's absolutely sort of normal walking. Because of the bilateral midfoot synovitis, he has got some deformities there, but alhamdulillah, some biomechanical issues persist, but overall, alhamdulillah, he's absolutely asymptomatic overall. So it's alhamdulillah, it's very sort of pleasing as well to hear these two stories. So it was very timely when we were working up for this particular course. And this particular session of spondyloarthritis that we have seen within last 2-3 months, these particular cases. So that's why I have asked them to come and share their stories with us to help us learn. Thank you very much. So we are done with our first session. So we are going to move on to the imaging in spondyloarthritis session. Ji, Assalamu alaikum again. So we are going to talk about now imaging in juvenile spondyloarthritis. Right. Right. Okay, so let's move on to the second session, which is, of course, the imaging in juvenile spondyloarthritis. So if you look at the techniques for imaging sacroiliac joints, for example, so we know about the X-rays. Of course, there are benefits and the shortcomings. When we look at the X-rays, for example, the benefits is, of course, it's a quick and the cheap, and of course, it's available in almost every corner at this stage. And the shortcomings are, which I've highlighted in an earlier session, is that, of course, the changes in X-rays take much, much longer. The other one is the bone scan, for example, which we used to use before the MRI become much more readily available, which we used to use for eliciting the joint inflammation, for example. And again, as I mentioned there, it may indicate early changes. And of course, it is a little controversial, because if somebody having osteoarthritis, for example, there could be some signal change in the sacroiliac joints in these patients. CT we use mainly if we are looking for the bone, for example, the erosion, the joint damage, for example, but again, it does not tell us about the activity of the particular inflammation, which of course we see and rely on MRI scan to look for very early changes. And of course, the issue, the shortcoming is the price and availability. So if you look at the sacroiliac joint anatomy, for example, it's one of the largest synovial joint in the body, but there's a very little synovium there. Of course, very little motion we know. It's a very complex shape if you look at, for example, there's a lot of curvature there in it, and there's a lot of significant retaining ligaments around it. So that's why the motion, of course, of this particular sacroiliac joint is not that much. And we know that it becomes much more lax in pregnancy. So it's important to understand that it has got two main components. One is the synovial part and the other one is the ligamentous part. The synovial part is the ventral or the inferior 1/3 mainly. And some books, some people talk about 1/2, but usually it's considered that 1/3 of the inferior part or the lower part of the sacroiliac joint is the synovial part. And this is the traditional joint, which I mentioned here, is with the fluid, synovium, and the cartilage there. And this usually we don't see that it enhances on these scans. And the other one is the ligamentous part, which is the upper part, the dorsal part of the superior part, again, 1/3 to 2/3 of this particular, of the sacroiliac joint. This is the non-synovial main. This again is a more cartilaginous part. So this is the sacroiliac joint. For example, if you look at the grading, for example, again, talking about the longevity of the disease, talking about the severity of that particular inflammation. So in the grade 1, we're seeing the top left corner, and the grade 1, which we're seeing is the right sacroiliac joint, for example, there are very subtle changes. Again, this is one of the things is that you really need to be discussing or thinking that whether it is positive or negative. And this is usually considered as a grade 1 with the right history again. In the grade 2, what we are looking at is that the sacroiliac joint, for example, there's a little bit of the widening there. Also sclerosis of the sacroiliac joint on the right one, what we're focusing on. Grade 3, again, there is a significant widening. There is a big erosions in the right sacroiliac joint there. And the grade 4 is when there is a complete ankylosis of the joint. This is considered as one of the last stage, or the burnout at that stage. This will be eventually happening. So these are the different, like sort of the 4 grades of sacroiliac joint X-ray, which how we sort of grade them. So bone marrow edema, now we are concentrating in the first part is the mainly sacroiliac joint. And then in the second part, we will be talking about the spine, sort of the vertebral column. So the bone marrow edema, this is very important for rheumatologists, for us all, because this means activity, means active inflammation. And as mentioned here is, this is the marker of active inflammation. When there's a high stir signal, means there's a high water content, which gets lit up on those particular MR images. So this particular case is 17 years old young girl with the juvenile spondyloarthritis. And the one what you're seeing here is on the left-hand side the arrow is there, but you can clearly see there is an intense inflammation. This is the stir image. This is the T2 stir image, which you're seeing is that there is a significant bone marrow edema. And there's a little bit of what we're seeing arrowhead there, which is just showing there's a little erosion there, but there's a little bit of what we call the backfill there as well. And in the joint there, but still we are seeing that the joint line is very much preserved when we're talking about the, for example, the left sacroiliac joint. On the right image, what you're seeing here is this gadolinium or the post-contrast T1 image. And again, highlighting or showing more or less the same thing what we're seeing from the stir image, that there is a increased uptake or the bone marrow edema on the sacral side, for example, in this particular one. And there is an erosion there, what we're seeing on the left sacroiliac joint. And so in this particular image, what we want to highlight is the bone marrow edema on the stir image or the gadolinium or the contrast changes there. So this is a 16 years old girl with, again, spondyloarthritis. And again, we are concentrating first on the left sacroiliac joint. Again, what we're seeing on this time on the iliac side is much predominant bone marrow edema. If we look at, for example, the right ilium as well of the sacroiliac joint, there's an intense bone marrow edema predominantly on the iliac side than the sacral side. And again, on the right side, again, is what I mentioned, the contrast enhanced T1 image. And also there is a high signal change, what we're seeing in the bone marrow. So this is one of our patients, and what we're looking at, again, the same inflammation happening, the bone marrow edema happening. On this particular one is predominantly on the sacral side. There's a very little uptake only in the inferior one on the iliac side. There's a predominant bilateral sacral significant bone marrow edema happening in the STIR image. So these are the two or both STIR image. There is no contrast given here, but these are showing the different slices of that particular STIR image. That is a very intense bone marrow edema happening in these two slices of bone of MRI STIR image. Again, as I mentioned there, it simply shows that there's an intense, highly active disease. So here, the slice A, what it shows is the T1 image without contrast. So what we are seeing here is that the low signal change happening on the iliac side of the sacroiliac joint, and the bottom one, the straight arrow, what it shows is there is also what we call an erosion happening in that particular area. There's a low signal change. And the panel B, what we're looking at is the STIR image, for example, the same changes what we're seeing on the T1 image, where there's a low signal intensity, it becomes much more lit up. When we're looking at the panel B, there's a high intense or the high signal change there. In simple words, it's showing the activity, there's the inflammation. So that particular inflammation or the marrow change will not let up, will show low signals on the T1, but it will show high signals on the T2 and the STIR image, of course, when there is a fat suppression there and all this. So this will only show the pathological, for example, changes happening in around the joint. So it's showing active inflammation in this particular image. So again, talking about the same of the bone marrow edema, here we're looking at the right, for example, the sacroiliac joint, the right upper part, what we're seeing, there's an intense uptake there. On the right, for example, the sacral side, much intense uptake of the bone marrow edema. However, also on the right iliac side, we're also seeing that there is an increased uptake there, which is all quite linear there around the left iliac, or on the right iliac side. But also in between the joint as well, what we're seeing here also is that there is, for example, this is what we call synovitis there. So it means there's a fluid inside the joint. And again, on the left-hand side, we are not seeing a lot of inflammation. There's a very subtle inflammation happening on the left sacroiliac joint. So it's the predominantly right sacroiliitis, which is quite active. So this particular case study, for example, if you look at the x-rays, for example, the x-ray of this particular patient looks absolutely normal looking x-rays. And if you ask me, I would call this a normal, absolutely normal x-rays. And the same patient, when he went on to have MRI scan, what we're seeing in the panel B is there is a very intense bone marrow edema happening on the both right and the left sacral side. The iliac side is preserved, but there's a lot of bone marrow edema, bilateral symmetrical uptake. Again, highlighting the same thing which I mentioned there earlier, that we should not be just looking at the x-rays. This patient had the back pain and very intense uptake, bone marrow edema on MRI scans showing active inflammation. On the C panel is the same, again, different slice of the STIR image, but this is the axial image. And the B panel is the more what we call the coronal image, and the C is the axial image, again showing that there's an intense bone marrow edema happening on the sacral side of the both sacroiliac joints. But in the axial side, there is also some uptake on the iliac side as well, along with the sacral side. And the panel D is the T1 image of the same patient, not contrast enhanced, but the simple T1 image. And the same, the bright signals what we're seeing on the T2 or the STIR image, that there is a low signal intensity happening in these T1 image. Again, very clearly highlighting that the low signals in the T1 and the bright signals in the T2 or STIR image showing active inflammation happening in this particular patient. So another patient looking at now the left sacroiliac joint, for example, in the panel A, if you look at the top arrow, there is an intense bone marrow edema happening on the upper corner of the sacral side, and this left side as well. There is also on the iliac side, there's an intense bone marrow edema involving almost most of the left iliac side. Important thing to here highlight for the rheumatology colleagues is that these dotted images, what you're seeing at the top image, the top side of the left sacroiliac joint, is that there is some uptake there. And this is what we call capsulitis. So there is a capsule of the particular sacroiliac joint. When there's an inflammation there, it shows up there right on the high up. Again, one of the markers what we use for active inflammation. On the left panel is the same, the contrast enhanced T1 image. And what we're seeing is literally more or less the same what we see from STIR image, that the bone marrow edema happening on the left sacroiliac joint, on the sacral side and the iliac side. And what we're seeing also is that there's a little widening of the sacroiliac joint and the sclerosis there, which we'll discuss later on. And again, the dotted arrow there at the top of the left sacroiliac joint, which means, in other words, there's an capsulitis, the inflammation happening around the capsule of the sacroiliac joint as well. Another patient, now very clearly what we look at, the panel, the top panel A, for example, the right sacroiliac joint, but if you can concentrate, we can clearly see very beautiful erosions happening, very nice erosions happening, but also at the same time, there's a bone marrow edema on the sacral side and the iliac side as well. And the same happening on the left sacroiliac joint, the both sides, there is a bone marrow edema. And also this is what we call, for example, little bit of the marrow change, inflammation happening along inside the joint as well. There is a little bit of synovial fluid as well. And also later on, there's a fat metaplasia, which I'll discuss in our next few slides. So this is more or less, this is the same patient which we looked at in our first, the last, for example, the image. If we can concentrate only on the right side, for example, the panel D, for example, in the same patient which we looked at, there was a bilateral sacroiliitis happening. And the same patient in the both hips, for example, there's an intense enthesitis happening, not only at the lesser trochanter, but also in the greater trochanter area as well, at the insertion of the various tendons, which are attached onto the greater tubercle and the lesser tuberosity. There's a lot of inflammation happening, consistent with enthesitis of this particular young patient. So it means there's an active sacroiliitis happening along with an active predominant enthesitis, bilateral symmetrical. So let's look at the second thing, which is erosion. Again, this happens, we know, learning from our peripheral joints, for example, of course, when the inflammation goes on for a much longer period of time, there is a joint destruction happening, which becomes manifested as what we call erosion. So this, the top one is a 15-year-old girl with the juvenile spondyloarthritis. We're concentrating on the left sacroiliac joint, for example. If you look at the x-rays, on the x-rays as well, you can see there's a sclerosis happening. There's a little bit of the whitening there as well, and some appreciation of some erosion happening there as well. So if you look at the middle panel, for example, so this is a STIR image. And here what we're looking at, of course, there is a little bit of bone marrow edema on the left lower end of the sacrum, but also there is a nice erosion, which is highlighted by an arrowhead there as well. There's a erosion happening in the left upper part of the sacroiliac joint. And if we look at, for example, the last right, for example, the panel is the contrast enhanced T1 image, and also showing the same, that there's an erosion there and there is no uptake of inflammation around that particular erosion. In the lower panel, what we're looking at is 11-year-old, another girl with the juvenile spondyloarthritis. We can forget about the left one. If you look at the middle one, for example, here what you're looking at is that there is a inflammation happening. There's a bone marrow edema on the both sides of the left sacroiliac joint, but also in the lower part of the left sacroiliac joint, there is an intense uptake of inflammation. This is what we call a backfill, for example. When there is an erosion, there's a gradually fill of some the fat, what we call metaplasia, in other words, or the backfill, in other words, which eventually would lead to sclerosis. So this is a little bit of close-up, if you can follow where the arrowhead is. So there's a nice erosion happening in these two images, what you're looking at. So one is the STIR image, and the second one is the T1 weighted contrast enhanced image. This was the one which I've shown earlier when I was highlighting bone marrow edema, but here you're also seeing a nice erosion sitting there. For example, in the panel A, in the lower straight, for example, the arrow, but you're looking at this particular one in the left sacroiliac joint on the lower side of the sacral side, there's an erosion there. In the middle part, of course, there's a low signal change, but when we look at the stir image, the same sort of the place on the stir image, there's an intense uptake going on. So it means there is an active inflammation happening, which has led to that particular erosion, but there's an activity still happening. So also in our young population, we need to be mindful of what we call the normal maturing bone. For example, of course, the cartilage is there and all this. So usually what we're looking at is, for example, the periarticular, what we call flaring. So for example, if you look at the left one, so very nice, for example, around you're seeing as there's a very nice periarticular flaring, which is thin, symmetrical, and subchondral. So this is what we call, of course, a growing, maturing bone. This is not, for example, the bone marrow edema or anything to be concerned about or to be worried about. However, on the right one, what we're looking at the image, there is a dark arrow there. So in the dark arrow upper one, you're looking at the bone marrow edema of the left iliac bone. So the bone marrow edema. But also if you look at the white arrow, for example, so that particular flare is the normal mature bone. So we need to be mindful, as I said, in this particular age group is that these signals might be the normal signals, but the normal maturing bone would look very much different. And it is very much analogous to what we call the normal metaphyseal signal, which we get in different bones. So this is the fat metaplasia. In other words, this is the middle stage. In other words, you start off, of course, active inflammation, eventually leading to erosion, and then erosion starts to get filled with around the same different fat metaplasia, what we call, and the backfill, if it is erosion, for example, and gradually this would lead into the full ankylosis or the more sclerosis there. But it's very important for us rheumatologists is that fat metaplasia signals are very much different. And that would tell us a little bit about the longevity of the symptoms. Here, what you're looking at is the fat metaplasia. For example, this is very much against or opposite to what we see in patients with active inflammation. For example, in bone marrow edema, when I mentioned earlier, so the bone marrow edema, the active inflammation would look low signals in T1 and bright signals in T2. In fat metaplasia, this is absolutely opposite, means that the T1, there would be bright image. For example, here in this particular slide, on the left hand, you're looking at the T1 weighted image. There's a bilateral, for example, increased signals on the both sacral side of sacroiliac joints, which is symmetrical on the both sides. And we look at the stir image, for example, there are low signal change there compared to the T1. And this is absolutely opposite to bone marrow edema, which I've highlighted there. So this, in simple words, means there's a fat metaplasia going on, means this is the next stage of inflammation. When the inflammation resolves, then the fat metaplasia kicks in, which eventually would lead to ankylosis or the sclerosis. So this is another image showing the same. Rather, this is talking about the looking at the both things. For example, the left one, what you're looking at, there's a bright signals on the T1. And also you can see the left sacroiliac joint, for example, there's an ankylosis has already kicked in. So this is ankylosed, not fully, but this is started to have ankylosis happening compared to if you look at, for example, the left sacroiliac joint. So there's a bright signals there in this particular one. If you look at, for example, the stir image, which is seems to be absolutely quiet, or the low signals there, again mentioning that there's a high signals in the T1, it's a fat metaplasia, but also in this particular nice image there, there's a both things happening at the same time, with the fat metaplasia along with ankylosis happening, which is unfortunately the last stage of this disease process. So we're done with the sacroiliac joints. Let's look at the spine. On X-rays, the spine, I think we all know very well that there's a squaring there, there's a bit of syndesmophyte happening, and the shiny corners. Eventually, of course, there's a syndesmophytes happening, and we all know about the, the bamboo spine, for example, happening. Sorry, I'm going to have a glass of water, sorry. So this is the spine X-rays. So this again, image of the squaring of the vertebra means the corners, of course, becomes eroded. So the vertebra looks like a square. So the corners become squared or they eroded because of the inflammation. This leads to squaring of the vertebra. Then eventually, of course, there's a new bone formation. There's a syndesmophytes happening. Then there will be bridging this syndesmophyte, and then the entire the spine becomes fused, what we call then eventually bamboo spine. But more we are concerned and gets really excited is when it comes to MRI of the spine. So there are a lot of different types, but to keep the thing simple, very simple, there are 4 different entities if you want to remember MRI of the spine. I know I might be confusing because I can understand there's a lot of like non-rheumatologists, of course, who does not have a lot of experience of looking at these MRI scans, but I'm also mindful that there are also, we have some rheumatology colleagues and our junior fellows who are attending this particular session. So that's why I'm not only touching the basics, but also I'm going to sort of help my rheumatology fellows and colleagues to help us understand about this whole MRI of the spine. And why I'm highlighting this here is because unfortunately in Pakistan, the reporting is very, very poor, absolutely poor. So in my center, and at least for my fellows, this is very clear that when it comes to MRI of the spine, MRI of the sacroiliac joints, we do not look at any the report, we look at ourselves. And I can remember easily while in Pakistan, then more than dozens of the time, the MRI was absolutely different. But when we looked at the MRI scans ourselves, we came up to absolutely a different conclusion. So the 4 entities, but we talk about the MRI of the spine. One is the spondylitis. This is the Romanes lesions, and then spondylodiscitis. Then there is arthritis of what we call the apophyseal, the zygoapophyseal joint, or the facet joints, in other words. And then there is some ligament inflammatory involvement. So let's look at the Romanes lesion. So these are the Romanes lesion. These are the corners that you might have heard what we call the shiny corners there. So these are the places where, of course, the annulus of the disc is attached onto the vertebral body. So the disc annulus is attached onto the vertebral bodies. So these are the types, these are the edges there. So this gets inflamed. And this is again typical what we looked at the sacroiliac joint, for example, the bone marrow edema. So the bone marrow edema, for example, in the T1, in the left hand, for example, so these are the 3 images you're looking at. On the left hand side is the T1 weighted image, where you're looking at the shine in the corners, for example. So there's low signals there, right? For example, if you look at the first, So if you look here, for example, the edge there, the arrow there, there's a less or the low signal uptake there. When you look at, for example, the T1 or T2 or the stir image there, for example, the panel on the right-hand side, there is intense uptake there or the bright signal change on those vertebral corners there. Again, talking about that there's an active inflammation going on. Again, back to the same thing which I've highlighted there earlier, when there's an active inflammation, there's a bone marrow edema, which of course would lit up on T2 and the stir image, and there would be low signal changes on T1 image. And this is what we see in this particular Romanes lesions. So this is an active Romanes lesion of one particular patient. So on the left hand, we're looking at the T1 weighted image. If we just follow the arrows there, so these are the corners. Again, the low signal changes on the corners there. In the middle one is the T2 image, which you're looking at the corners becomes lit up more. But if we look at the far right side, for example, which is a stir image, and you can see clearly that those corners are very nicely, much more brighter, much more shiny looking, again, highlighting that there is an active inflammation going on at the activity of that particular disease process. So the second one, again, talking about the active Romanes lesion on the left-hand side is the T1 weighted image. So the corners which there are the arrowheads there, we're looking at the low signal change there. But the right side, which is a stir image, there's a much hyper intense or the bright signals on those vertebral corners, which are highlighted by those arrows there. Again, very much opposite to T1, which highlighting again that this is an active Romanes lesion. So fat metaplasia, which I mentioned in our sacroiliac joint. So the same process also happens in the spine as well. Again, as I mentioned there, this is an aftermath of active inflammation. This is the middle stage, which eventually will lead into the development of syndesmophyte. Here, what you're looking at on the left-hand side, the bright signals on the T1, these are the fat metaplasia, or the backfills, in other words. And on the right-hand side is the stir image, and the same bright corners, the bright sort of the edges on the T1, they are not letting up on the stir image, highlighting the same that this is what we call fat metaplasia. This is again the same one. Another images looking at, for example, on the left-hand side is the same T1 weighted image. On the right side is the T2 weighted image. So this can be a lot of mixture of those changes happening at the same time. So this particular, for example, patient has got mixture of the both, that there's an active inflammation going on, and also at the same time, there are some chronic changes happening as well, manifesting as fat metaplasia. So let's look at the second important one, which is what we call Anderson spondylodiscitis. So in other words, there's a disc inflammation. So again, this is, as you can see there, I hope you can see on the right-hand side image, there's a disc inflammation going on. There's a, this is a T2 weighted image. So there's a bright, for example, the signals happening in the disc, in the middle part of that particular disc. It's the same thing which you're looking at, for example, the top part of that particular image, what you're looking at, there's a very bright, for example, the signals which you're looking at around the disc. So means there's an active inflammation going on in the disc. So here, if we can concentrate on that one, the top part you can forget, because as I mentioned, there are shiny corners and all this happening, but also at the same time, in this particular patient, Romanes lesions are happening, but also at the same time, there's those Anderson spondylodiscitis happening. So the left hand is the T1 weighted image, and here what you're seeing, the lower part, for example, of that particular L5S1, what you're looking at, there's a low signal intensity happening, but which is bright on the T2 or the stir image, again highlighting that there's an activity of the disease, but also at the same time, there's also overlying fat metaplasia ongoing as well at the same time. Here, talking about the same, the left-hand side is a T1 weighted image. All the active inflammation that you can look at, for example, so there is a low signal intensity in the middle part of the discs, for example, or the middle part of the vertebra there. All those low signals becomes much more lit up, much more bright when we look at the stir image, which is on the right-hand side, showing there's an active discitis happening in this particular patient. Again, highlighting the same thing, discitis in another patient. For example, there's the low signals on the T1, and there's a much more bright signals happening in the stir image at the different various levels of the disc, again showing that there's an active inflammation of the spine happening because of spondyloarthritis in this particular case. Another patient as well, there's a much intense inflammation happening in this particular case at L4, L5, L3, L4 level as well. So highlighting, I think this very a nice sort of images, but you can see, especially at the L5, L4, 5, there's a, on T1 weighted image, there's a low signal change there, but on the stir image, there's a much higher, much brighter uptake of inflammation happening on the stir image. At almost all of those, the stir image, if you can look at almost all the discs, what you're looking at, there's the bright signals there. So this particular patient has a discitis at almost all lumbar levels. Again, just short of the time, I'm just going to move on. So let's talk about the arthritis of the facet joints. So this is, we all know about the facet joint, what it look like. So in this case, what you're looking at on the left-hand side is the stir image. There is a, for example, the arrow what you're looking at, there's an inflammation. There's a very bright signals happening at the facet joints. For us, it's very important to understand that what particular slice of that MRI scan we're going to look at the facet joints. So again, we're looking at a little bit of the outer side of the main vertebral bodies when we reach to the facet joints. So it's very important that we look at all the different slices of MRI scans when we look at the picture of those slices. Again, another image as well, looking at the intense inflammation. On the left-hand side is the inflammation at the stir image, for example, and on the right-hand side is the T1 weighted contrast enhanced, where there's a, again, bright image happening showing the apophyseal joints, which are much more inflamed in this particular patient of spondyloarthritis. In this case, again, all the Romanus lesions happening as well. There is some sort of the spondylodiscitis happening as well. But also at the same time, for example, if you look concentrate on the left panel, there's the inflammation happening at the various levels. For example, if you look at this one, there's the apophyseal joint. Almost all the apophyseal joints are inflamed in this particular left panel, what you're looking at. On the right panel as well, this is again T1 contrast enhanced image. Again, the same bright signals which you're looking at the stir, they're also lit up on the contrast enhanced image, showing intense inflammation of almost all the apophyseal joints which you're seeing. But also there is a inverted arrow what you're looking at here. There's an also enthesitis of what we call interspinous process, interspinous ligaments, in other words. So there's an inflammation in this particular. So there's a lot for us to look at the MRI of the spine, not just the shiny corners, but also disc as well. But also if we move peripherally or the laterally in the apophyseal joints, there's a lot of enthesitis happening, which we can find out. For example, in this one, what you're looking at is the costovertebral joint, which is also quite pathognomic, which we do not see in any other almost particular arthritis, pathognomic of spondyloarthritis. Here, what you're looking at, again, this is, we are moving laterally of the main vertebral body. There's an intense, what you're looking at on the left hand, the sagittal image of that particular MRI scan, what you're looking at, the solid arrows, what you're looking at, what you're seeing, there's an inflammation happening, and this corresponds to where our the rib tubercle is attached onto, or the costovertebral joint, which is highlighted on the right hand panel. For example, I wish I would have some sort of the laser to show you, to highlight, but here you're looking at, there's the inflammation of the bone there, which is attached onto the vertebral body. So there is a rib attached onto the bone or to the vertebra, which is inflamed in this particular case. So here another, the stir images, the sagittal image, what you're looking at on the front, what you're finding is that there's an inflammation of the manubrosternal joint, which is an arrow at the anterior edge of the right, the image what you're seeing, there's an inflammation of the manubrosternal joints. Here, what you're seeing is that inflammation of the vertebral bodies, and these are again the places where the ribs are attached, or the tubercle of the tubercle of the rib is attached onto the vertebra, which is inflamed. And on the right hand side, the arrows are pointed towards this, which is quite hyper intense signals there on those particular two areas where there's an intense uptake or the inflammation of costovertebral joints or costovertebral arthritis, which I mentioned in the right setting. This can be very pathognomic for spondyloarthritis. Here, I think this is a nice image, one of our patients. So here, what you're looking at on the right-hand side, this is stir image. This is the rib is attached onto the vertebra. And here you're saying that there is an bone marrow edema of the vertebra where the rib is attached onto the vertebral end. There's an inflammation, the signal change, the high signal change means the marrow edema, but also there's the erosion there happening as well on the both sides, right and left, showing that there's bilateral sort of costovertebral arthritis with the inflammation active. Also at the same time, there are erosions there happening as well. This is another patient as well, highlighting the same, the costovertebral. I'm really sorry, I wish I had the highlighter there or the laser to point out those changes. I think it would be a lot easier on this particular image. This I got from the one of the radiology atlas. So here it's easier for you to look at because the arrow is placed there. You can see there is an intense uptake of inflammation. For example, if you look at the left panel, so this is the vertebra. So the vertebral inflammation or the vertebral high signals eliciting active bone marrow edema. And also at the same time, the rib is also, where the part of the rib is attached there, there's also inflammation happening. The soft tissues, there is also inflammation. So pretty much showing that there's a very active costovertebral arthritis happening in this particular patient. So in summary, So I think, I hope and I wish that I've highlighted in all this particular session is a couple of things. One, very, very important is that do not rely on X-rays. X-rays take much, much longer before they become abnormal, and that can take years and years. And I've mentioned it can take easily up to 5 years. It can even take up to 10 years even. So we really need to be good at, really looking at the MRI scans, and being the rheumatologist as well, and the students in rheumatology, we should be better than a regular radiologist in having a good understanding of these images. I think we are done with our session, and we can now open the floor for question and answer session. We are delighted that Dr. Kamran is also with us. Question. So, any questions from the audience?
Thank you, Dr. Harun. Obviously, I joined a bit late, so I joined at the end of second case, but very nice presentation and imaging. I think there are a few questions that I can see in the messages. Shall we do one by one?
Yes, please. Yes. So,
okay. I think
the first one-
242 asked the question first.
So let's start with the questions. The first one, if I can go down there. So the first one is, how do you weigh between anti-TNF drugs and IL-17 blockers? So if you look at, for example, the data, so data is very much comparable even in the adults spondyloarthritis as well. And the same, as I mentioned there, even in our juvenile spondyloarthritis, for example, I didn't have the time to go through the formal studies of anti-TNFs versus and the IL-17 blockers. But
Are you doing the spring rolls, Mama?
Yes, yes, the mask part of जल्दी से they are nearly ready. तो आप भी बनाया आपके लिए. पैंट नहीं पहनी आपने, पजामा भी तो दे देते.
एक सेकंड.
चलो शाबाश, जल्दी से मास्क पहन लो, देखो रेडी हो गया.
I'm sorry, there was a lot of disruption there. We keep on turning on the mute button, but just unfortunately keeps on getting unmuted. So the first question was about the anti-TNFs versus the IL-17 blockers. So if you ask me personally, I think the both are very much comparable. Again, it's the personal choice. For me, probably both are the same. Can I request again to the audience? Do not.
Spring rolls with feta cheese.
I agree with Dr. Harun.
Okay, so as I mentioned there, so the both are comparable. We can discuss in detail, but that's all a more academic discussion than anything. But the both are very much comparable. Anti-TNF drugs have been in use for last number of decades for this particular disease in adults and the juvenile group with absolutely wonderful results. And the same has been shown for juvenile population as well.
I agree with you, Dr. Harun. I think both have shown promising results. Obviously, NTTNF has longer safety data and experience. What we have seen in UK that late adolescents, we've seen them responding a lot better to IL-17 versus NTTNF, and a lot of time where NTTNF failed, IL-17 helped. But I don't think that there is any reason to make IL-17 as a drug of choice or make NTTNF as drug of choice. I think every patient has different circumstances. The important thing is to remember that spondyloarthropathies are a lot more responsive to early use of biologic, and whichever biologic is available, whether NTTNF or IL-17, it should be used sooner rather than later.
Thank you, Dr. Kamra. Thank you very much. It's very helpful. The second question is about the use of etanercept in these patients. Absolutely, etanercept is an absolute wonderful drug for these spondylitis, active inflammation. So I absolutely would agree that this could be usable in these patients.
Again, it's one of those things that obviously etanercept has been used longest than other biologics, and therefore you'll find more studies on etanercept than others. Our usual practice in UK is that when it's spondyloarthropathy or axial arthropathy, we tend to use adalimumab. And when it's enthesitis related arthritis, lots of enthesis, then we tend to use etanercept as first line. But in UK, we're very much bound by nice guidance and what we can prescribe or what not. But personally, I would favor adalimumab more than etanercept. If I have a choice, I would choose adalimumab rather than etanercept for these patients. Again, it doesn't mean that etanercept can't be used. Adalimumab has other benefits as well, twice monthly dose versus etanercept twice weekly dose.
Thank you, Dr. Kamran. Then the next question is about the contrast MRI. The cost is much. Can we rely on stir image? Absolutely, yes. We do not need, when it comes to spondyloarthritis, we do not need contrast enhancement. A stir image will do absolutely the same as the contrast. And that I have absolutely highlighted there. The contrast, of course, becomes more beneficial when you're thinking about, for example, malignancy or some sepsis or something. But usually in our talking about spondyloarthritis, for example, scenario, we do not need contrast. I'm highlighting again. So do not request contrast, please. Stir image will give you absolutely the same images, the same signals, very reliably as the contrast will give you. So thank you very much for highlighting this point. So
again, our practice here in UK is that we have very MSK trained radiologist. So we generally don't request contrast whatsoever. We only request scan, and radiologist with the live scan, during the scan, they decide whether contrast is needed or not. So it's very, I think where the radiologist has sound knowledge, it's very useful for them to apply that knowledge to help. But I agree that as a routine, contrast is not indicated, especially when stir facility is available.
Thanks. And the next question is, which level of spine is involved, first of all? So usually, again, there are a lot of differences there because, of course, the patient phenotypes are different. Usually, sacroiliac joints are the first one to get affected, but not always. In 21%, again, I'm not aware of juvenile spondyloarthritis data, and I can almost guarantee there's no data in juvenile population. In adult spondyloarthritis, if you look at the 21%, only 21% of the cases, the sacroiliac joints can be normal, and the disease is predominantly in the spine. So in other words, so predominantly it's the sacroiliac joint, the first one gets affected, But again, it all depends on the symptoms. So if somebody doesn't have any spinal pain or spinal stiffness, of course, naturally, you can rely that this patient does not have spinal pain or limitation. In psoriatic arthritis, for example, the sacroiliac joints is, of course, again, more commonly affected at the same time, but the cervical spine, for example, is much more commonly affected when it comes to psoriatic arthritis. So there are subtle phenotypic differences there when it comes to what particular part of the spine is affected. But as if you ask me overall, of course, the sacroiliac joints gets affected first, and then the spine. In the spine, again, the Romanes signal would be the first one that becomes positive, and the castrovertebral joints or the apophyseal joints, usually they get affected very late. So they are not usually the first signs what you'll find. And rather, one of the studies, which I didn't get the time to show you, but I had that one slide there, which this study particularly showed that the Romanes lesion or the discitis has to be there before you see usually the apophyseal joint or the castrovertebral joint affected. So the next step is when in arthritis, we will give steroids. Of course, steroids we use, as I mentioned there, as a bridging therapy. So these are not the long stay treatment option. These are there only for the bridging therapy. Of course, they are effective, as I mentioned there. So they're very, very effective. But again, using the same word again, that we use it for bridging therapy before we start some other form of DMARDs, either conventional synthetic, for example, or biologic DMARD, depending on. So there's the next question is about update on tofacitinib in spondyloarthritis. In adult spondyloarthritis, tofacitinib has been licensed for treatment. So it does work in ankylosing spondylitis, for example. In UK, if I can remember, in NICE has recommended some use of tofacitinib in juvenile spondyloarthritis. But again, this will not be the first one that I would use. If you ask me, I would prefer biologic DMARDs rather than the tofacitinib for spondyloarthritis.
I think you're absolutely right. JAK kinase inhibitors didn't really show much promise in treating spondyloarthritis, especially in pediatrics. I don't know a single unit that uses tofacitinib or baricitinib, even as second or third line therapy. So most units use anti-TNF or the IL-17, so like adalimumab or secukinumab, but definitely tofacitinib or baricitinib is not something that we use commonly. Again, just because a medicine is available and the company has done studies in various inflammatory problems, and they have shown results in the calculated study population. So we need to understand that when the medical companies present the data, that's within a very controlled population with a exceptional adherence, 100% compliance, and blood monitoring and everything. So what I'm trying to say, just because something has become available doesn't necessarily mean that we should jump and use it.
Thank you, Kamran. Next is a patient with inflammatory back pain, typical history there, but normal inflammatory markers and normal MRI. How to proceed? I think it's very important that this particular case, I have a number of cases of those ones. Of course, these are the typical one, what we call non-radiographic spondyloarthritis. And naturally, these patients would need treatment. Rather, biologics have been formally licensed for these sort of scenarios only, of course, if there is a real need. But these patients, I would treat them just like the same if I'm concerned or if there is a right scenario. Inflammatory back pain, again, if you look at, for example, the sensitivity and specificity is 75 to maximum 80%, means that still 25 to 30% of the patient, plus minus, of course, might not be having true inflammation, but there would be some features of inflammatory back pain. So again, in the right settings, for example, in the right family scenario, if that is the case, I will be treating that case as spondyloarthritis, just like similar to any other patient. For example, I'll give you a simple scenario of the family that comes to see me is a young guy, I think is 19 or 20 something. So he has got active disease, already got significant bone marrow edema, erosions there. He has got limitation of the cervical and the lumbar spine movements. And this time, I think it was 2 months or thereabouts, his younger brother comes the same, like on the same visit. And he says, oh, I have some back pain as well for last couple of weeks. And I was thinking like, okay, just might be. So I gave him off the record, I gave him like, okay, some NSAIDs. And he came that he was a little bit better. So we got his inflammatory markers and they were absolutely normal. So I thought his back pain is gone. It was only there for 2-3 weeks. The inflammatory markers are normal. Pain is all settled. So forget about it. But his father was, of course, very much concerned because they had seen their sort of other son who had been suffering with this and he's already got deformities. So they got an MRI. So next time they comes in with an MRI, which I had not requested. And to my bloody surprise, there was a significant bilateral bone marrow edema in this particular patient, who this time comes to me with the normal, the back pain was gone, with the normal inflammatory markers, but the bone marrow edema on those MRI. So again, these things happen. So that's why what I tell is that the family history and the right case scenarios are important. For example, in this particular case, of course, the NSAIDs absolutely revolutionized, completely cleared his back pain, number one. Number two, his brother has got ankylosing spondylitis, who is HLA-B27 positive. So there's already a lot of noise there in this particular story. So these things happen. So that's why very important to understand that the clinical history and the clinical context is vital. And we treat them just like any other patient with spondyloarthritis. So the next one is tell us about, there is a lot of biologics available, how to decide which one to go about. The biologics, of course, there are a lot and lots available in Pakistan now. Alhamdulillah, we have got availability of number of them. Readily available, expensive, but not that expensive. If you look at what they can do as regards the treatment. For example, if you ask me, I'm very clear that which particular group you're targeting. Again, we should be mindful of a couple of things. One is, for example, secukinumab, which is once a month, compared to, for example, etanercept, which is once a week. And also we have got biosimilars, which are twice a week. So again, these sort of things we need to be mindful of when we're deciding the therapy of biologics. And also we need to be mindful, there are certain biologics where the TB reactivation risk is very high. For example, adalimumab and infliximab, the reactivation of TB risk is very high, is one of the highest if you talk about compared to secukinumab. The secukinumab data, if I can remember, I'm talking about 2 years earlier data in the whole world, they had only one patient with the reactivation of the TB that was in Brazil. And the investigators were very clear that this was not the reactivation. This was actually some new, and that patient moved into somewhere else. So in other words, so these are a couple of things which would help us decide which particular patient to focus depending on the drug we're using and of course the logistics involved. Overall, the price is no major difference. The price usually comes around 30,000 to 40,000 a month overall for these patients. But again, also at the same time, we need to be really mindful that what I do in my patient is that the moment we achieve induction, I try to sort of slowly wean them off these particular biologics. And there is only one reason behind it, and that is the cost. For example, in Europe, we did not even try to sort of wean them off. If we had to wean off some medication, we used to use with the methotrexate, for example, or for example, the NSAID, for example, not the biologics. But in Pakistan, unfortunately, I end up doing opposite to what I used to do in Europe. Here, the moment we achieve remission, we try to reduce down the biologic, again, purely based on the cost for the patients. And alhamdulillah, so far, we have published data as well. Even in the Annals of Rheumatic Diseases, we have published our data and showing that how slowly, if we slowly wean off the biologics in these patients, we still can maintain some success in these patients. So in the right context, in the right settings, everything is achievable. And of course, we all aim for the best for our patients.
I'd just like to emphasize that the purpose of these meetings is not to allow everyone to start these medications in any setting. Biologics are medications that we should use with respect. And I think they should be used with caution and under guidance. So with proper pre-start investigations and ongoing monitoring of these medications. So therefore, I think that only tertiary centers, people working in tertiary centers should take these decisions, and then once somebody is established in biologic, they can be monitored in the local centers as well. And this is at least what happens in Western world, and we don't, in Pakistan, we don't even have resources compared to Western world. So I think it's even more important that people who know how to manage complications should start these medications and have clear guidance about what to do, when to do, which bloods to monitor, and all these things.
Thank you, Dr. Kamran. I think the last one we're going to deal with is what is the process of weaning off biologics? There's no particular process there. Everybody has their own sort of tricks, if you like. So we have our own protocol. Again, it's very much self-devised. There is no sort of background to it. It's very slowly. I'm happy to share if people want to. So we slowly wean off those biologics, either the dose if possible, or the more commonly what we use is we increase the space of the time when we use these biologics, again, very slowly.
So I'm sure Dr. Haroon will remember from his time in Ireland as well, that weaning off biologic is it's not really a thing. So generally what people do in these patients, and especially in children, sometimes in children it's easy because if you allow them to grow and don't change the dose, then they automatically wean off. So that's a good thing about being a pediatric patient, and if you need to wean off. But generally taking a patient of a child who has inflammatory arthritis from any medication, whether DMARD or biologic, they should have a symptom-free, a flare-free period of at least 18 months, if not 24 months. And then you can start weaning off. For biologic, there's no hard and fast rule, but usually you can wean them off within 4 to 6 weeks, up to 3 months. Some people do it over 3 months, some do it over 6 weeks, and some just stop it. But the important thing is to try to keep patients on methotrexate when you are weaning off biologic, so you have some backup as well. And make sure that you see these patients more regularly after weaning off, so that if there is any bounce back, then you catch it early. After stopping somebody's biologic, if they have one-off episode of inflamed joint, we don't necessarily need to restart biologic straight away. You can treat it with joint injections or short course of steroids, and that may deal with the problem, and you may not have to restart biologic all the way again.
Great. Thank you very much, Dr. Kamran. We're absolutely thankful, Dr. Kamran, that you joined us for later half of this session. I know you're struggling with your disease, and inshallah, I hope you're getting better. Thank you very much again for all your help. I think we are out of time at this stage, and we can close today's session. So thank you very much for everybody. And it's an absolute pleasure, as I said earlier, to have you all in this sort of the joint or the combined learning session, which inshallah ta'ala will continue doing for the next few months to come. Thank you very much again. Assalamu alaikum, everyone. Stay blessed.
Thank you. Allah Hafiz.